All right, once again, welcome to Antibiotics and Antivirals. Very fun way to start your Monday morning. So these are the 11 drugs that we're going to be covering for antibiotics, so let's get straight into it. So these are just some general definitions that you'll have to unfortunately learn for the exam. They're pretty self-explanatory, so you can just look over this yourself. But important words are prophylactic, which means preventative medications, empirical, not proven, and directed, which means the culture susceptibility is known. And the types of antibiotics that we have, you guys are going to learn that we classify antibiotics in so many different ways. It gets so confusing, but one of the most basic ways is whether it's static or cidal, which means static, slow, inhibits growth, or cidal, like kills, basically. So knowing that, we relate this to what we call inhibitory concentration or bactericidal concentration. So MIC just means the lowest amount of drug that you can give to a patient that stops the bacteria from growing in them, whereas MBC is the lowest amount of drug that you give to patients that reduces the population itself. Because we're always trying to give the lowest dose to patients because you don't want to jack them up with too much drugs. And MEC is the minimum effective concentration, which is the minimum amount of like drug that plasma concentration, which is amount of drug in the plasma blood, required to produce a desired effect on the patient. So this is important because if you look in the corner over here, we have this little graph showing the areas where like the more you give to a patient on a y-axis, you go from not effective to bacteriostatic to bactericidal. And yeah, you just need to know this for the exam. So bactericidal drugs, at the very top, the most like deadly, I guess, they interfere with more important things in the bacterial life cycle, like cell wall formation, because you don't have a wall, you just die. Whereas bacteriostatic, which is in the middle section here, inhibit things like protein synthesis, which means the bacteria wouldn't necessarily die maybe, but it would prevent them from being so toxic and being so bad. But obviously most drugs are cidal. You'll see this more in a second. So mind me, this is something that you should definitely memorize. And it's pretty simple. It's basically saying how you should, as a doctor, prescribe antimicrobial agents to your patients. So you want the narrowest spectrum. So you don't want broad spectrum because you want it to be more targeted to prevent antibiotic resistance. You want to minimize duration of therapy and all of those obvious concepts. And once again, if you see in this corner here, we have a similar looking graph to the previous slide. And the important thing to take out of here is it's basically talking about the therapeutic window, which means the amount of drug between the minimum and the maximum that you can give to a patient before it gets too toxic or not good enough. So therapeutic window, just remember that word. Alrighty, and time dependent, that's another way of classifying if you want to take a look at that later. So going through cidal and time-dependent effects, the main way that we can categorize antibiotics is by what part of the bacterial life cycle they target. So it's pretty obvious if you just think about it sequentially, like bacteria have a cell wall. You get into the cell wall, you break it, they die. And then once you get into the cell, into the cytoplasm, there's folate happening, there is protein synthesis, and then that is something else that you can inhibit. And you get further into the cell, you have the nucleus. If you target nucleic acid synthesis, you can also kill that bacteria. So this diagram just shows you the different classes of drugs. They're not specific drugs, they're classes that each area targets. And you don't need to memorize most of it, but some of these will become important as we go on. Sweet. So once again, how to classify antibiotics. In this little lecture slide, every single drug that you guys will need to know, or at least at our year level needed to know, is going to be green and bolded. So these are the core antibiotics. There's 11 for you to learn, or maybe more if you're different. And as you can see on the left, there's a lot of different drug classes with a lot of weird names, but the crux of it is that different drug classes do different things. They can either target protein, cell wall, or nucleic acid, as we said before. And yeah, you'll see more later. So this is the main thing that I wanted to talk about today. So when you study pharmacology, I remember hating pharmacology so much last year because there was just so much to learn with like modes of actions and side effects. So I found that using memory tools, and these are the ones that I memorized, was good enough to get me through the exam, good enough to get the second year. And I really recommend you guys to learn bio-mnemonics because there'll be so many drugs. So let's start with something simple like amoxicillin. Amoxicillin is a penicillin because they're both cillins. And remember, penicillin is a class of drug. And that's important to remember because lots of patients have penicillin allergies. So you can't use amoxicillin, you have to use stuff like cephalexin or other classes of drugs. So amoxicillin is a penicillin, penicillin the cell wall because penicillin affects the cell wall. Sweet, okay. And cephalexin, flexin, strong enough to break a cell wall. Doxycycline, cycle, remember you're on a bicycle, you can fall off a bicycle, so it's reversible. This is a weak one, I know. Cyclists need good bones and kids need bones. So don't give it to kids because you'll break their bones. 30S, it works on the 30S subunit, and it all looks, and the 30S subunit looks like a bicycle from bird's eye. Does that make sense? Hopefully. So just look over this in your spare time and just memorize the mnemonics. Okay, so next section, we've done these slides for you guys so that there's a bit of information on each one. And to be honest, this is probably the maximum that you guys need to know for your core basic knowledge. You'll find lots of other slides maybe that have a lot more info, but honestly, I like to keep it simple. So what I've bolded is the important stuff that you will actually need to use in clinical and not just memorize for this exam. So stuff like cephalexin, very important because you use it for penicillin sensitive patients because a lot of people in the society are actually allergic to amoxicillin and penicillin and stuff like that. Vancomycin, super important because it's used for severe infections like MRSA, which you find in the hospital a lot. And here are some more. Erythromycin causes GIT, hepatic, cardiac side effects. You'll find that a lot of antibiotics causes GIT effects. So when like there's an exam question that's like, what's the side effect of this antimicrobial? I would just write down GIT because usually it's GIT because you take these via mouth and they all work similarly down there. Clarithromycin, just randomly, it increases risk of arrhythmia, which is like random heart movements. Gentamicin increases effect of NMJ blockers, if you've learned that yet. Doxycycline is important. This is a big one to remember because we use it as for a few things. Remember how doxycycline, cycling on the bike, you fall off the bike, you break your bones, and children need bones. So you don't use it for kids. And because it has calcium effects, it gets rid of calcium. So bone growth and teeth, there's issues in there. And it's also used for malaria prophylaxis. Remember, prophylaxis means prevention. And acne, which is random, but helps me remember. And here are some more, just read them in your own time. But rifampicin and isoniazid, these are part of the RIPE drugs. I'm not sure if you guys have learned that. But RIPE are the 4 drugs that we use for tuberculosis, which is like a super, a really, really bad respiratory infection that people can get. Rifampicin, it's easy to remember because you're like rifampicin, you're pissing. So you get a lot of orange, red piss or pee when you take this drug. And it's important to remember that tuberculosis drugs are all really, you need to use a few of them on each patient. Like usually I think people use RI and P together and they've got horrible side effects. So it's really horrible when you have tuberculosis, but because of so much antibiotic resistance, you have to use a multi-drug therapy, which is important to remember for a lot of antibiotics that you're gonna learn. Okay, these are just some cute pictures that my friend drew. So you can look at these to help you remember if you want. So, okay, hopefully I haven't been going too fast, but let's do this question. So which drug for tuberculosis causes orange-red bodily secretions? Nice. It is C, rifampicin, because you're pissing all that orange pee. Fun, fun. So which drug is given to penicillin allergic patients? All right, it's B. Very well done. Amoxicillin is a bit tricky because you have to remember it's a penicillin, not a different kind of penicillin-like drug. All right, and that's antibiotics done. Not too hard, hopefully. So now we're on to antivirals, and these are the 6 ones I will be going over today. Remember that antivirals always end, well, usually end with the. So remember it that way, and then you have oddballs like emtricitabine. So okay, so antivirals are different to antibiotics for a few reasons, but the main reason is that you don't have broad spectrum antivirals like you have broad spectrum antibiotics like amoxicillin and all that. So because of that, we don't actually have a lot of antiviral medications available in this world, like at all. If you see in this table over here, these are the main ones that we use in clinical, plus a few other random ones and immunizations. But these are the ones that you should probably be aware of. Also, viruses, like as you know, the flu virus mutates every year, so we need to like create a new virus, antiviral every year, and that's another reason why we have not so many antiviral medications available. But it's honestly okay because most viral diseases are ultimately self-limiting and no medication is needed. Because whereas bacteria can like proliferate so quickly and have all of these toxins that can kill you in so many ways, viruses are kind of chiller, I guess. But we also use combination therapy to fight these guys as well. Now, again, this is similar to the antibiotic slides for the ways that you can kill a virus. You can prevent it from attaching. You can prevent it from uncoating, from making proteins, nucleic acids, and from leaving. Like neuraminidase inhibitors, like you guys learned about like neuraminidase. It's used it's on the influenza virus, and it prevents, and using the antiviral prevents its release outside of the cell. So again, just think systematically, think step by step, and you'll understand the process. Antiviral medications also depend on the genome, whether it's single-stranded, double-stranded, DNA or RNA. If it's a retrovirus, HepaDNA virus, there's a lot of different types that you'll learn next year. So leave the weird names out of it for now. So before we get onto the actual medications, these are important latent infections that you guys should know. Latent means that it lies, it just basically stays inside your body, doesn't do much, just chills until one day like it gets really bad. For example, chickenpox, you've probably seen this in every GP clinic. There's a picture of an old lady and she has a lot of red around her face and her arms. This is shingles, which is when the chickenpox virus, which you guys learned in the dorsal root ganglia, sensory, stays in there for years and years and is reactivated one day when people are older and have worse immune systems and they become shingles. So careful if you have chickenpox. And HIV, we all know. Glandular fever is a type of herpes virus. Most of these are herpes viruses actually. You can see in the right box here, it's herpes virus is a very prevalent one. And again, similar to varicella zoster, this one lies in the dorsal root ganglia. Never forget that dorsal root ganglia is sensory. That's where all the sensory fibers lie, and that's where sensory infections happen. Okay, so cool. You can look at that later and do some more research if you'd like. This is the same thing. So let's go on to HIV. HIV you're going to learn a lot about if you haven't already. But antiretroviral therapy is what we use to treat HIV, and we use that mostly to just slow down the virus and prevent it from getting any worse, because unfortunately there's no like real solution to it right now that can completely cure the disease. But the issues are resistance and loss of adverse effects, as with a lot of other antivirals. So basically, over here, you see that the drugs that we use are NRTIs and NNRTIs, and these are basically types of reverse transcriptase inhibitors. And they just prevent reverse transcriptase from working, I guess. But it's important to remember some of these acronyms here, and also to note that mutation is really common with NRTIs and PIs and most other HIV medications, which is why we use a lot of triple therapy, as you can see in this image here. Like we said with tuberculosis, you need lots of different drugs to work at the same time. So reducing HIV transmission, public education, prophylaxis, which means prevention, and using antiretroviral therapy so that when you do engage in sexual intercourse, it can decrease transmission to your sexual partners and to your fetus if you are pregnant, down to 2%, which is pretty impressive. So remember PEP, post-exposure prophylaxis, and pre-exposure prophylaxis, two of which we will be learning about today. So a summary like we had before. Probably everything on here is all you need to learn, but indications is the most important part. As you can see, acyclovir is for herpes and varicella zoster, like we talked about before, the latent infections. Ritonavir, easy to remember because R is RNA, HIV. Yep, and here are the memory tools. So acyclovir, clover, green, guanine, analog. And clover is luck, so lucky you don't have shingles or herpes. And also tamivir, easy to remember because this is what we use for the flu, Tamiflu, flu influenza, neuraminidase inhibitor, as we said before. Interferon alpha we use for hepatitis B, C, cancers as well, but mostly hep B and C. So remember alpha, beta, hepatitis B. Ritonavir, tons of people have HIV, RIP. No proteins in Doritos, so like the ritonavir. So it's a protease inhibitor. Okay, and this is the same info basically, but just remember the clinical usage, I guess, and a bit about how it works. Remember how it works using these memory tools and you'll be good as gold. So just have a look at this in your own time, and that's all. So thanks guys for listening. Good luck for studying all of this. I'll hand over to whoever's next now.
Alrighty, thanks Rachel. So I will be trying to find, can everyone hear me, by the way? Just pop a yes in chat or anything. Yeah, cool, thank you. All right, so I'm basically going to be presenting hemostasis and coag. So as a side note, before I start explaining anything, I'm just going to let everyone know that these are actually Jess's slides. So if you've got any questions, please ask them in Curious Cat because Jess knows these slides so much better than I do. Okay, I can't seem to get rid of that, but that's all right. So if you've got any questions, ask them in Curious Cat because Jess will probably give you an answer that's so much better than mine. So yeah, so I haven't written any of these slides either, so just letting you know that any questions probably direct them straight to Curious Cat or to Jess herself. So let's get started. So we're starting with hemostasis. So before I get explaining, I'll go through what hemostasis is in general. So you can probably tell from the name, it's literally just a system that will help you to seal your injuries in your body, usually via something like a platelet plug and like a fibrin clot formation. And all these steps are literally just in place to stop hemorrhage in your body. So hemorrhages like profuse and like major bleeding. All right, so there are 3 major steps that you'll have to hemostasis that Jess has got on the slide. So first of all, your blood vessel is going to constrict. That's your vasoconstriction. And it will decrease your blood flow to the area, so to that damaged area. The next thing is your platelet plug. So we have like the damage to the endothelium of your blood cell, and that will actually promote the activation of your platelets. Note that the platelet plug is temporary, and then it will form crosslinks using fibrinogen bridges. Okay, so now you've got this creation of this platelet plug, and that's basically going to lead to the activation of events that will form your stable fibrin clot or your stable plug. So fibrin is entangled around the platelet plug, and it's formed through a series of steps that you can see on the slide. And it's basically going to be rebound, and it will make an insoluble network that we know as a fibrin clot. Okay, so there is a number of coagulation cascade pathways. So on the side, there's the pathway, and unfortunately, you guys will have to actually memorize this. So last year when I was doing this, I actually got a really handy tip from PSPs, which I put on this slide, which is a really easy way to remember just how to actually just go through the slides, because unfortunately you have to memorize all of these numbers like 12A, 11A, 9A, and everything. So it is quite annoying. But basically, this is your coagulation cascade. Each one of these numbers are coagulation factors. And they're basically factors that are involved in your coagulation cascade, and there are a bunch of substances which act on each other and are eventually going to lead to the formation of that clot down the bottom. So these factors can be either enzymes or cofactors, and almost all of them are going to be synthesized in the liver, which means that if you've got liver damage, so like in chronic alcoholism or like liver cirrhosis of any kind, then your coagulation can be affected and inhibited, which is a really bad thing. All right, so fibrin, as mentioned in the previous slide, it's known as 1A. And you can see this here in the diagram. It's the very last step in clot formation, and it needs to be activated by a whole heap of like other factors that you can see up the top. And you also probably should remember which factors need vitamin K. So vitamin K is your AUS TV channels, so Australian TV channels, which are your 2, 7, 9, and 10. And Jess has put in a fun fact as well, which is basically that using vitamin K can reverse warfarin, which is an anticoagulant. So there are two pathways for your coagulation cascade, which we'll talk about a bit later, but they're basically your intrinsic and extrinsic pathway, but they both are going to end up in the same result, which is your coagulation and your stable clot. All right. So once the damage to like the tissue and the endothelium has been healed, your clot will actually undergo fibrinolysis. So a number of different signals can lead to the activation of your plasmin, which used to be plasminogen, and plasminogen is the inactive precursor of plasmin. And plasmin is basically just an enzyme that's going to break down the clot. So fibrin is broken down into a bunch of different products, one of which is the D-dimer, which you can measure in the blood. So this is actually a test or a screening test that we can do. And this is a marker that will help with thrombosis diagnosis. So TPA, which stands for tissue plasminogen activator, and UPA, which stands for urokinase plasminogen activator, both are going to help you basically to activate your plasmin. But you can also inhibit this by inhibiting TPA and UPA. And if you do that, you'll basically lead to plasmin not being activated. So you'll have no fibrinolysis occurring at all. All right. So here there basically are a number of different tests for hemostatic function. And we're going to basically mainly discuss your coagulation screening tests. I think in the lecture that you guys had on this topic, there was a bunch of tests, but a lot of them are very low yield. But we're going to go through the coagulation screening tests just because they're a bit more important and a bit more high yield as well. So there are three main tests, as you can see on the slide, that faculty really want you to know. So it's APTT, which stands for activated partial thromboplastin time. You've got your TT, which is thrombin time, and PT, which is prothrombin time. And I don't think it's not too important that you actually remember what they stand for, because most of the time you'll just see them as TT or APTT. So don't like agonize over what they stand for and memorize that too hard. And essentially each of them are going to measure different parts of your coagulation cascade. So you know that we've seen the intrinsic part, which is in your pink. Your blue is the extrinsic pathway, and your purple is your common pathway that both of them are going to activate. So as a side note, the coagulation cascade is really complex, but like the three main pathways are quite important that you understand and just figure out what they do. So for example, intrinsic is from your contact activation. So it's basically activated from damage within your blood tissue or your blood vessel. Whereas your extrinsic pathway is the tissue factor pathway, and it's basically going to be activated by damage to the tissue itself. And your common pathway always occurs regardless of like which what's going to actually start it. Yeah, so APTT, as you can have a look from the diagram, it's mainly from your for your intrinsic and your common pathway. Your PT is mainly for your extrinsic pathway, and your TT is just for the common pathway. There are a couple of other tests that you might have seen in your lecture, which aren't mentioned on the slide. So they're the D-dimer fibrinogen levels. Don't stress over them too much because they're not that high yield, and they're not that exciting either. So here are some hemostatic disorders. Honestly, these are really low yield. I don't think I remember seeing any of them, not really, in any of the exam questions that I've done, but they come up in Clin Skills in year 2, so in our year in SEM 2. So basically, these are just different types of bruising that you can get because of the blood that's pooling underneath your skin, and these are just basically disorders that you get when blood's not where it's meant to be as a result of a clotting disorder. So I'm going to quickly go through those. Okay, so this is really important. So please know them. So basically there are 3 factors that can contribute to thrombosis. So thrombosis is basically the development of blood clots. So the first one is an endothelial injury. So this is when the coagulation cascade is initiated. And as the name suggests, that's when there's some issues that are going on with your endothelium. The second one is abnormal blood flow. So it's usually when you've got like turbulent flow or blood's not moving through the vessel properly. So when blood's not moving through, we call that blood stasis. So it's just like not really moving that much. So 2 extremes. And then we've also got abnormal coagulation. And so this is when the factors and the cascades that you actually get are abnormal. So for example, it might be like a mutation in your prothrombin or like your factor 5, factor V, or whatever. All right, so that takes us to the end of hemostatic disorders. So we're going to go through and whiz through these slides, which are just on antibiotic resistance, because you guys have already pretty much done this, but this is basically the microbiome theory against them, and we're going to go through them super quickly because Rachel's pretty much already covered these, and the main part is the farm, to be honest. So resistance is the ability to basically just resist bactericidal or any kind of parasital or anything really effect of like some kind of like chemotherapeutic agent. So it's what we're trying to avoid, especially in hospitals. Otherwise, we get the rise of bacteria like MRSA, which is super hard to control. Okay, so there are 5 main targets that we have for antibiotics. So Rachel talked about the cell wall, but we also have things like protein synthesis, nucleic acid synthesis, metabolic pathways. So for example, antibiotics can act on specific enzymes that you might find in bacteria that might do specific actions in the bacteria cell wall. So it might like, or the cell in general. So it might like inhibit the growth of the bacteria, or it might inhibit the multiplication of the bacteria. And it can also interfere in cell membrane functions. So those are the 5 things that antibiotics are trying to target in your bacteria cell. There's also a little mnemonic, mind me, about how we can prevent antimicrobial resistance. I'll let you guys have your own look at this, but most of them are pretty straightforward, but they're also quite important to remember at the same time. All right, so there are a couple of mechanisms of antibiotic resistance that we'll have. So we can split these into innate resistance, acquired resistance, and non-genetic resistance. So examples of these have been put onto the slides for you. All right, there are some features of bacteria that can also help it to acquire your antibiotic resistance. So transformants are all about the uptake of DNA from the external environment. Conjugation is the transfer of DNA between two bacterial cells, and transduction is the acquiring of DNA from a bacteriophage. So it's basically just three different methods and three different environments from which a bacterial cell can actually get DNA, and that DNA might code for like an enzyme or something might help it to acquire antibiotic resistance. We also have plasmids. So plasmids are DNA molecules that are used to separate the host chromosome. They are separate to the host chromosome. So you're going to have like the big chromosome in your bacteria, and then you'll have like these little ring molecules, which are plasmids, which are quite cute. But they can be transferred using conjugation. So that was one bacteria to another. And so these genes are also really important. So you can have a read of them in the slide as well, because they carry a lot of specific genes, not only just resistance mechanisms, but also a lot of different really important genes that are separate to the actual chromosome of the bacteria. And the last feature of bacteria that we're going to have a look at are transposons. So they're really cool jumping genes. So that they're like mobile DNA elements, which often carry like resistance genes, and they can move DNA in a number of different ways. So they can go from like plasmid to plasmid, they can go from like a plasmid to a chromosome, or to like a chromosome to another bacterial chromosome. And so they're really cool. And there are basically two main types of transposons that we have, and their insertion and composite. And yeah, that brings us to the end of week 11. So thanks so much, guys, for tuning in. If anyone has any questions, once again, all you have to do is just go on to Curious Cat, just because these are just the slides. I hope I was okay at explaining them all to you. Otherwise, thanks so much for coming, and I hope you guys have a good week 11. And good job last week for finishing your OSCs as well.